Tēnā koutou katoa. Ko Andy Salmon, toko ingoa. Thank you very much for the opportunity to come and share with you the new update in the chronic kidney disease in adults pathway. The chronic kidney disease in adults pathway was updated about 18 months ago. And there are two main reasons for that. One is risk stratification, and the whole management of chronic kidney disease is now built around the risk that individuals have with their chronic kidney disease. And the second reason for that update was the availability of new tablets that completely change the prognosis of chronic kidney disease. Essentially, that's empagliflozin. And so we'll just run through this here. This one? Super. Chronic kidney disease is really common. So 2 studies in New Zealand now, one in Southland, one in Auckland, show that the prevalence of chronic kidney disease is about 10% of New Zealanders. Unfortunately, that's a significant number of people in this room. 1 in 25 New Zealanders will have high-risk chronic kidney disease. So this is common. This is a problem that is frequent in New Zealand, frequent across the world. Those represent global prevalences too. We're not unique in that. But Māori and Pacific people are about twice as common, twice as likely to have chronic kidney disease, and those groups of people are more likely to have high risk and progressive chronic kidney disease. So chronic kidney disease impacts patients. So I've highlighted there that chronic kidney disease is a risk factor for cardiovascular disease. So one striking fact that I wanted to get across today is that chronic kidney disease is a more significant risk factor for cardiovascular disease than diabetes is. Chronic kidney disease also impacts patients in terms of other outcomes. So infections, hospitalizations and mortality are all substantially increased in those with chronic kidney disease, and that the risk of all of those factors increases with severity of chronic kidney disease. Now, chronic kidney disease also impacts our management. So firstly, it's a long-term condition and is therefore going to require long-term monitoring. Secondly, medication adjustment is going to be a really frequent thing that we need to do for people who've got chronic kidney disease. And as I mentioned, empagliflozin is a drug that can slow progression of chronic kidney disease. So for many years we've had ACE inhibitors and ARBs, and that's essentially been the mainstay of our ability to slow progression of chronic kidney disease. For those who are going to progress to kidney failure, ACEs and ARBs probably slow progression by about 4 years. Empagliflozin probably slows progression by about 15 years. For those individuals who are going to end up having dialysis in their life, that's a long time to be doing other things other than coming to the dialysis unit 3 times a week. There is no uniform screening program for chronic kidney disease in New Zealand. In parallel with countries across the world, it's a targeted screening approach for those with risk factors. And so these are the major risk factors for chronic kidney disease. So starting up on the right-hand side, I've touched on Māori and Pacific people. Those of Indo-Asian ethnicity also have high incidence of chronic kidney disease. Chronic kidney disease is more common with age. Your EGFR does go down with age, but it's still possible for you to have symptomatic or significant consequences of your chronic kidney disease as your EGFR drops with age. You still need the medication adjustment, etc. Those with prostate or urological disease. A family history of chronic kidney disease is a really significant factor for kidney disease in subsequent generations. Medical issues, obesity, heart problems, stroke, diabetes are all risk factors for kidney disease, and nephrotoxic medications would be a good stimulus for checking for kidney disease. So how would you do it and when would you do it? So a kidney health check is simple. It's 3 things. It's a blood test, a urine test, and a blood pressure check. So your blood test is an EGFR. Your urine test is a urine albumin-creatinine ratio. And your blood pressure check can be done in the clinic, can be done at home, but hypertension is a significant feature of chronic kidney disease. When to do that? Starting at the bottom, the cardiovascular risk assessment is an ideal opportunity to capture this. So EGFR and urine ACR, EGFR is required in the cardiovascular risk assessment because EGFR less than 30 is a cardiovascular risk equivalent. Urine ACR, this is a great time to do it. Monitoring or initial screening for end organ damage and annual monitoring in hypertension and diabetes, for those on medications that can impact kidney disease and those with clinical concerns, so particularly acute intercurrent illness in those who already have chronic kidney disease. So how to make the diagnosis? The diagnosis takes 3 months. You need 2 tests 3 months apart in order to be able to diagnose chronic kidney disease. It's the same test both times. And if your EGFR is less than 60 or your urine albumin creatinine ratio is above 3 on your first test, then you should repeat those tests. You should ideally repeat them in 1 to 2 weeks to make sure this is an acute kidney injury, and then repeat them at 3 months to make the diagnosis. Chronic kidney disease is usually asymptomatic, so this is an incidental diagnosis. And if your EGFR is below 60 for at least 3 months, and your urine ACR is above 3 in at least 2 samples over 3 months, then you have chronic kidney disease. Once you have that diagnosis, here are the major steps for what to do. So exclude those major differential diagnoses, and that top right, that's the acute kidney injury. That's why you repeat those tests on a short time frame. Register chronic kidney disease in long-term conditions. So this was one of the other major points to highlight today. Studies in the US and in Europe have shown that people who have chronic kidney disease, only about 10 to 20% of those people have chronic kidney disease registered in their long-term conditions list. It just doesn't get added to the list of diagnoses. And preliminary work that we've done in Auckland unfortunately shows that we're about the same. About 90% of these cases are not added to the long-term conditions list. So that's an opportunity to pick that up. Looking for CKD progression on the right side, if EGFR is falling by more than 5 per year, and particularly if it's under 45, that's high-risk disease. Looking for the underlying cause, so a urine microscopy would be your first test. Ultrasound if they've got high-risk features, and then intrinsic renal disease tests. Now I'm going to move on to staging and risk stratification. So this is a heat map of everybody's chronic kidney disease. It's staged 1 through 5, and below 5 is when you get onto dialysis. Stage 1 or stage 2 kidney disease, if you have an EGFR between 60 and 90, but normal urinary albumin, then you only have chronic kidney disease if your kidneys look abnormal, if you've got polycystic kidney disease or you've got abnormal pathology. The yellow boxes are low-risk disease. So this here is where EGFR is above 60, but you have some albuminuria. These orange boxes are where you have more significant moderate risk kidney disease. So EGFR might be between 30 and 45, or between 45 and 60, with some albuminuria. And everything that's in red is high-risk disease. So those with a low EGFR below 30, or with significant albuminuria, urine ACR above 25 or 35, depending on your gender, that's high-risk disease. Now, most CKD is managed in primary care. We're grateful to you for that because we can't see 10% of the population. These are the people who can be well managed in primary care. So those with a stable EGFR, I've defined progressive EGFR. Diabetes, if your EGFR is above 45, if your EGFR is below 30, we would want to know about these people. If urine ACR is above 70, we would want to know about these people. If there's hematuria, we would want to know. If their blood pressure is difficult to control on 3 or more medicines, then we would want to know. And the Auckland Region HealthPathways now has a yellow action plan, an orange action plan, and a red action plan, depending on where you sit on that heat map table, depending on what your risk is. And the yellow action plan is essentially monitor once a year, talk to people about their diagnosis, tell them that if they become sick, they might need to miss out their ACE inhibitor, they might need to get a kidney check. Blood pressure target, we're going to say 130/80. lipid lowering, review medications, and particularly for those in diabetes, if they can access empagliflozin, we will be supportive of that. If you're in the orange boxes, then your action plan is more frequent monitoring, looking for complications. So I've not listed all of those here because they're long, but they're all in the Auckland Region Health Pathways. Adjust the medications, cardiovascular risk again, and refer if people are outside those criteria. And then the high-risk individuals in the red boxes, monitor more frequently. Expect to manage complications. We would often be involved if people have got substantial albuminuria or very low EGFR. So referral when you meet those criteria. So to finish, here are the key points. So CKD is common. It impacts people and their management. Where possible, if CKD is present, registering it in their long-term conditions list is a really good prompt for adjusting medications and enrolling in regular follow-up. A kidney health check is simple and needs repeating over a 3-month time frame, and doing that at the same time as other screening, so cardiovascular or end-organ complications. Many people can be managed in primary care, and those different action plans support the management of people on the basis of their risk. Thank you.